presentation is to explain the supraspinatus anatomy and to understand the correlation to musculoskeletal ultrasound. There are two ways of scanning the supraspinatus, longitudinally and in the transverse plane. The first is placing the patient in cras position, the second in modified cras position. The modified cras position is sometimes also referred to as the Middleton position. If the patient sits in the cras position, the shoulder is in extension and full internal rotation. The dorsal hand is placed on the back and the upper arm close to the chest. The extension of the shoulder ensures that the supraspinatus adopts a ventral position. It appears from the subacromial space. Not extending the shoulder results in not being able to scan a big part of the supraspinatus because we can't scan through the acromion to visualize the supraspinatus. So, in order to visualize it, the patient needs to extend their shoulder. The full internal rotation twists the supraspinatus in a vertical position with its fibers proximally to distally orientated. If we take the new fibre orientation of the supraspinatus into account, we need to place the transducer on this ventral shoulder in a horizontal way. Orientating the transducer laterally to medially will visualise the transverse or short axis of supraspinatus. To visualise the supraspinatus in cras position longitudinally or on the long axis, the transducer needs to be orientated proximally to distally by placing it in a vertical position on the ventral shoulder. Thus, one could say that in cras position, both transducer positions combined will create a plus sign. Memorising C+ will make you remember that in cras position, the transducer positions are orientated as a plus sign. If the patient sits in the modified cras position, the shoulder is in extension and slight internal rotation because of the hand placement on the iliac crest or the back pocket. Important to note is that the patient's elbow should point posteriorly. This modified cras position leads to less internal rotation of the shoulder and therefore also a diagonal fibre orientation of the supraspinatus. Placing the transducer on the modified cras fibre orientation results in a proximal to lateral towards a distal to medial orientation to scan the supraspinatus transversely. The longitudinal supraspinatus in the modified cras position is scanned by orientating the transducer proximally to medially, towards distally to laterally. If we combine both modified cras transducer positions, a sign of an X can be seen. Memorising MCX will help you remember that in modified cras position, the transducer positions are orientated as an X sign. The modified cras position has the advantage of showing the supraspinatus tendon more completely, extracting the full myotendinous junction, and it also provides a better view of the rotator interval. Both positions are advised when scanning the supraspinatus, as sometimes a pathology is better to see in cras position and sometimes in modified cras position. Let us have a look at the transverse and longitudinal sonoanatomy. This is the transverse short axis of supraspinatus tendon. Please note that the supraspinatus looks like a tyre on a wheel. Ultrasound visualises the hyperechoic cortex of the humeral head, the hypoechoic hyaline cartilage and the synovial fluid, the transverse short axis, hyperechoic supraspinatus tendon, indicated with the letters SS. The subacromial subdeltoid bursa is seen as an anechoic film of fluid between two hyperechoic bursal sheets, and the hypoechoic deltoid muscle indicated with the letter D. This is the longitudinal long axis of the supraspinatus tendon. Please note that the supraspinatus looks like the beak of a bird. Ultrasound visualises the osteology of the greater tubercle, the column anatomicum, and the humeral head with its anechoic hyaline cartilage and synovial fluid. The myology shown in the images is the longitudinal long axis of supraspinatus and the deltoid muscle. The subacromial subdeltoid bursa is shown as a long hypoechoic line between the two hyperechoic bursa blades. The column anatomicum is a major pitfall in ultrasound. Due to the concavity of the column and the oblique course of the footprint tendon fibres, the zone around the column shows hypoechoic, a result of anisotropy. The pitfall is that this zone is also the zone where there is a high incidence on tendon tears, which also shows as hypoechoic zones. Therefore, it's crucial that the sonographer differentiates between the hypoechoic anisotropy and the hypoechoic tendon tears. This is done by changing the transducer inclination. If the hypoechoic zone turns hyperechoic due to this transducer inclination, you can see that it had been anisotropy. If the hypoechoic zone stays hypoechoic, then it's most likely pathology. Another area of the supraspinatus tendon at risk is the footprint. The parts of the supraspinatus tendon that insert to the greater tubercle. The supraspinatus is quite broad and long, so make sure that you always scan every part of the supraspinatus. This is an example of the parts you should scan when assessing the transverse short axis of supraspinatus. This is an example of the parts you should scan when assessing the longitudinal long axis of supraspinatus.